welcome back from what I hope was a restful long weekend. Thank you for being with us at the download. This is MiHIN's monthly but regular webinar diving into the intersection of healthcare and technology. If you have been here before, thank you. If this is your first time, you should know that the download is really meant to tackle these larger topics. Whereas we have a companion webinar called Bits and Bytes, where we really try and get into like the nitty gritty technical, getting in with the development and product managers of whatever it is that we are discussing. So welcome today to the download. Next slide, please. We are recording. We have people monitoring the chat. My name is Joanne Jarvie. I am the Senior Director of Customer Experience, and I am thrilled. Every day I'm thrilled to be working with Katie, who is our Vice President of Strategic Acceleration. And today we're going to be talking about imaging and about how health information exchange, specifically MiHIN, Michigan's statewide network, can support imaging, imaging use cases. So next slide, please. If you don't know, now you know that MiHIN is Michigan's designated statewide entity to exchange information, personal health information, securely, privately, technically, legally. We represent a growing network of public and private organizations that are trying to connect to overcome data silos. We are a neutral data steward. We exist between very powerful sectors in order to make sure that information is flowing for the right purposes at the right time to the right people. We have no agenda. We are here to exchange information. Next slide, please. Just to give you a sense here, our network is comprised of different types of entities, right? We are connected to the federal government, our state government, our health departments, all payers in Michigan, all health systems in Michigan, and hospitals and clinics and practices and FQHCs, pharmacies, physician organizations. We exist to help get information to the people who are helping patients. So we exist to be connected to doctors, to nurses, to clinicians, to care managers, hopefully in the future, dentists. We have about 5,637 Michigan care entities connected to our network. We have 13.1 million unique patient records that we are responsible for securely exchanging information on behalf of, and around 44,582 Michigan care providers. And we know this because those are the care providers who have established active care relationships with patients and are therefore looking for these patients' critical health information through our network. Next slide. So as you think about who MiHIN is connected to, you have to think about why we are connected to these entities. And more and more, we are thinking and asking the questions, what information are you looking for? And for what purpose? Information that goes to a doctor or a nurse in real time may save a life. And that is for the use, the purpose is of treatment, right? But the data that we exchange in aggregate, and when you look at information stacked on information, and you start asking questions about it, it's used for healthcare operations, which is not always the same as treatment. It is used for payment under HIPAA, treatment, payment, healthcare operations. And so more and more, even when you sort of come online and you ask us questions about what we do and why we do it and how we do it, we are going to come back to you and say, are you looking for this information for purposes of treatment? Are you looking for this information for purposes of healthcare operations? Are you looking for this information for purposes of payment? And when we start moving through and into consent directly with patients, they will want to know the answers to these questions as well. I am going to step back now and introduce Katie. And I will be here for any questions. I'll be here to keep us moving. You can always chat me. Let's move on to the next slide. Okay.
Good morning. Thanks, Joanne. Good morning. Thank you, first off, everyone, for joining us. As Joanne so very graciously introduced me, my name is Katie Goulet, and I am the Vice President of Strategic Acceleration for our MiHIN family of companies. I have the pleasure of speaking with you today about the breast cancer imaging pilot. This initiative is really designed to improve the quality, the efficiency, the cost effectiveness of women's healthcare delivery with a specific focus on breast cancer diagnosis and treatment through exchange. I'm specifically going to talk to you about our imaging hub benefits with respect to this pilot. I'm going to talk to you about the sending of radiology reports and the current data flow that we have built to support this. And I'm also going to talk to you about the status of the breast cancer imaging pilot and how you can get involved. To guide this discussion, we're going to begin by talking about the background and the overview. How did we get here? We're going to talk about the defined value of this solution. We're going to talk about the exchange capabilities of this solution and all the different things that we are attempting to tackle with it. We are also going to be talking about the guiding principles of the pilot, the data flow, accessibility, and again, the next steps. Next slide, please. According to the Office of the National Coordinator, or more commonly referred to as the ONC, an HIE really allows healthcare professionals and patients to appropriately access and securely share patient information electronically. As Joanne mentioned, we are Michigan's statewide and state designated health information exchange. And we are really seeking to enable stakeholders across the entire healthcare ecosystem in our state to efficiently receive and exchange diagnostic images across multiple disparate systems and vendors. In order for us to identify the current barriers to this efficient image sharing and exchange, we needed to really take a step back and look at how we were going to do discovery of those artifacts to create an effective, valuable solution. We really stand by the fact, with that said, that we need to be clinically led and technologically enabled. So how do we ensure that happens? Next slide, please. We use our proven use case factory mechanism to do that. We gather our stakeholders, we discuss challenging issues that have been presented, we solicit feedback from these experts, and we collectively pull all of those different threads together in a white paper that is published. This process genuinely allows us to understand the situation from these folks that are dealing with it day to day. They're presented with these patients in front of them, they are tackling these issues, and they are trying to provide more proficient healthcare at the bedside. They help us to identify the key pain points that they might be experiencing with this, and then we really are able to determine and create and provide interoperable solutions to improve patient care for the communities and the patients that we're serving. So in June 2021, we did just that. We hosted a 5-part imaging workshop series. We convened these stakeholders and we identified these current barriers to efficient image sharing. So what did we find? We found very specifically that there are some very large, admittedly, overarching um, areas of improvement. And what we identified them to be is that we really need to find a way to reduce imaging duplication. We have patients that are going to a multitude of health systems, a multitude of entities across our state environment. And because that information is not actually being shared, they are having the exact same imaging studies being performed over and over again. This is, in effect, creating, of course, wasteful spending. And it is, more importantly, creating a lot more radiation exposure to these patients. When we took this information back and we really thought much more deeply about this, we recognized that imaging in itself is a very expansive area. We also recognized that we could not create an effective and valuable solution if we attempted to, as they say, boil the ocean for this. So we started actually doing more discovery once we had this white paper and once we'd done this convening of our stakeholders and our experts. We started doing discovery across additional arenas, such as environmental scans, regulatory and legislative investigation, to start to understand an area that we might be able to hone in on and that we could actually do a strong focus to make a difference. What we found after all of this investigation and conversation is that there's a very strong focus on women's health, both at the federal and state levels. We then took that back and identified a targeted pilot use case solution to support breast cancer imaging exchange. I want to make sure we also note that we also identified through a lot of this investigation the importance of the exchange of the breast tissue density in addition to these imaging result reports and the imaging itself. I'll speak more about that in a little bit. But we didn't just stop there. We had all these ideas, we pulled all these threads together, and we said, does this make sense? Because, again, we want to be clinically led and technologically enabled. So we reached out. We reached out to one of our lead radiologists from one of our largest health systems. And through conversations with that radiologist, we confirmed that breast cancer imaging would in fact yield a very substantial benefit for all involved. Next slide, please. So now that we had confirmed this trajectory of the solution that we were going to try and target first, because again, imaging is so large, we looked at what technology elements we would need to start to solve for some of these overarching areas for improvement. And we found that it really boiled down to these 4 items: the need for a statewide imaging registry, the need for availability of imaging data, especially within our emergency departments, metadata elements of the images themselves, which would allow for normalization, which would allow for comparison. And we also found that it would really require image enablement and exchange between multiple disparate vendors. Next slide, please. So while all of these are very lofty goals, we really looked at this and said we still need to distill down a smaller scope so that we can be effective. So we split apart our efforts really into 3 phases. We built a proof of concept imaging registry for breast cancer imaging studies that would allow for these phases to begin, starting specifically with phase 1, which would say we could obtain and allow access and availability of breast cancer imaging registry result reports, which is a mouthful. We would also have the goal of that to include normalized imaging metadata in the future. Once we really got our arms around that first phase, we would then move into the potential to make these images viewable. And then lastly, we would need to move into how we would fully exchange these images from PACS to PACS, PACS to VNA, et cetera, across the state of Michigan. I want to be very specific that today we are talking about phase 1 of this. and our pilot is targeted towards phase 1. So
Katie,
next slide,
can you
please.
say breast cancer imaging? Does that include all breast imaging, like ultrasounds and MRIs, or only mammograms? Is it only 2D, only 3D? Like, what is breast cancer imaging? What are we including?
We are not paring this down to be restrictive. And so what I mean by that is if there is a mammogram, if there is an ultrasound, if there is anything of that specific part of the body, we would include it if it is sent. Does that help answer the question, Joanne?
I hope so. I think it might. We'll hear from
Okay.
Katie if it doesn't.
Okay.
Yeah.
Thank you for monitoring the chat. I apologize. I'm not looking at the chat
No,
also.
you can't.
Okay. Next slide, please. So define value. As Joanne had mentioned above, specifically, we're looking at the value provided for this solution across the treatment, operations, payment, and of course, we would be remiss if we did not include the patient experience here. So while there might be additional levels of value that could be included and could be stated for these areas, we specifically are looking to create visibility to the imaging result reports, improve the quality of care for these patients, surface and exchange the breast tissue density, and enable access to the results for eligibility coverage potential, and overarchingly promote and enhance patient experience by reducing the burden on these patients. Next slide, please. So furthermore, as we delved into the clinical value of this, we were actually able to connect with one of our stakeholders that is not only a general surgeon with a focus on the breast, but is actually also a breast cancer survivor herself. She educated us on the importance of surfacing and exchanging the breast tissue density in addition to the imaging result if it's made available by the sending organization. So we wanted to share a little bit of this with you all today to understand why this is important for it to be sent, and also why it's important for us to make sure that it is available for exchange in addition to these results, or on these results is a better way to say that. So specifically, this physician educated us in that 40% of women have dense breasts. Women with dense breasts are actually 4 times more likely to develop breast cancer. And over 50% of mammograms will actually miss cancer on dense breasts. Next slide, please. We were also educated that there are multiple federal laws to address this. And effective June 1st of 2015, in Michigan specifically, there is actually a Michigan law that requires that mammogram service providers inform patients if they have dense breast tissue on their screening mammogram. I want to show you the picture on the right-hand side of this screen. And you can see that there's actually a risk stratification of dense breasts. It goes from alpha all the way to delta. And if you specifically look, you can actually see the difference in how that dense breast will shield or hide potential malignancy. So specifically, if you go and you see in alpha, there is a circle around the dot. And there's a dot right in the middle. I don't know if, Kaylee, if you can point to it with the cursor. But, yep, over in A specifically. So over in A, you can see it. You can see it very clearly. This patient does not have dense breasts. The more dense the tissue, going from risk stratification of B, C to D, you can actually start to see how it is being hidden and much more difficult to see. When we talked to this physician specifically about this, she was adamant that it is so important, and obviously by educating us, we certainly understood that we needed to make sure that this is shared. So in our solution, we are making sure, and this is very important in the red at the very bottom here, If this is included on the result report, it will be exchanged for the other care team providers to see it. Next slide, please. So specifically, what are the capabilities of the pilot solution that we are looking at and that we have created? This pilot solution will allow for prior and present image results to be exchanged between the patient care team. This is based on the fact that they have an active care relationship, what we have coined ACRES, with that patient established. We will then leverage our existing data feeds for those radiology result messages, or ORUs in more technical terms, to identify and make sure that we are actually able to resolve the patient or identity resolve the patient in that inbound message feed through what we call common key service, or more commonly referred to really as our MPI. We are then able to actually take that information once we have identity resolved the patient, we have established that they have a relationship with that provider. We're able to take that information, convert it to FHIR, and register that imaging study in our clinical data repository, or more commonly referred to as a CDR. We then are able to make it available in our longitudinal patient viewer. In the future, we are going to be looking at how we will enrich this data with additional metadata for future use. Some specific examples of that would be anatomical regions and the additional information with respect to the modality of what was completed. Next slide, please. So who are we doing this with? We have been having multiple discussions and really looking at firming up a partnership with the Breast and Cervical Cancer Control Navigation Program. That's a mouthful. It's much more commonly referred to as BC3NP within the state of Michigan. For those of you who are not familiar with BC3NP, it is a federally funded program by the Center for Disease Control, or CDC. It is administered by MDHHS within the state of Michigan, and they provide low-income women access to breast and cervical cancer screening services and follow-up care if needed. Specifically, this program doesn't pay for cancer treatment, but women who are eligible, once they have these screenings completed, are able to work with BC3NP to identify if they may potentially be applicable for a Medicaid program that will cover their treatment. But what's very important here and how we are able to help them with this pilot solution is that in order for BC3NP to coordinate a patient's care with the potential eligibility, they require access to the patient's imaging result reports. Today, I think as most of us are aware, you would need to go into multiple disparate systems. You would need to access all of the surrounding health systems that these patients may be seeking care at. And you would have to attempt to retrieve those result reports. The staff at BC3NP is doing just that. And there are several staff that are engaged to do this every day, hunting and pecking down result reports, if you will. We are looking at this pilot to actually help them get this information in a one-stop shop, one location. Our guiding principles for this pilot with them include exchanging the imaging result reports across the state of Michigan in a vendor agnostic way. They include obtaining past and present images to coordinate this level of care for these patients that are uninsured and or underinsured, specifically with a focus on health equity. We are also looking at, with these folks, how do we reduce the administrative burden and resource hours that is currently spent attempting to track down these images? And how do we increase the patient experience by providing this information in a much more readily accessible way and decreasing delays in their care for the next level of care? Next slide, please. Our pilot solution will be to use our proven network of networks approach. It is to aggregate the imaging result reports across the state of Michigan, ensure the needed care team holds an active care relationship with the patient, and provide access to the patient results in one location. As an example, I'm going to walk through what this would look like. So if you are following along with me, on the left-hand side of the slide, we have example patient Trisha. Trisha has a radiology study performed. The facility that it is performed at sends an HL7 ORU to the trusted data sharing organization and then to MiHIN. MiHIN retrieves the image metadata. We identify and identity resolve the patient. And then we convert the message, the ORU, into FHIR. We register the imaging study in our CDR, and we make it available for access in our longitudinal patient viewer. Next slide, please. These image results can be accessed via the longitudinal patient view in our MyGateway application. As some of you may be aware, we are also undergoing a transition right now to a new longitudinal patient viewer. And this is an example of what it will look like. We will be able to show the procedure performed for this patient in a list, much like what you can see here in the test screenshot. We will be able to show the sending facility. We will be able to show the breast tissue density, and we will actually be able to make that report downloadable or viewable as needed. This information, as I believe I've laid out, really will reduce the continued administrative burden of trying to hunt these items down, because this information will be patient-centric and will be available across the multitude of health systems that we are connected to today and organizations at large. Next slide, please. So what are we looking for with respect to this pilot? We are looking for, and how can you get involved, I should say, we're looking for radiology results to be sent from all organizations statewide. If you are not sending us results, we please ask you to outreach to us, and there is one of our points of contact listed on here. It's Lisa Nicolau. She's our director of cross-sector data sharing. We're asking you to reach out to us. We need this information in order to make it available. We have quite a bit of information today, but we are definitely asking, how can you get involved for these types of efforts? Because the BC3NP pilot is not the only one. We are also saying, if you would be interested in engaging in this type of pilot, specifically for breast cancer imaging exchange, let us know. We want to see how we can get you involved and how we can help you. Maybe you have different guiding principles than what we laid out for BC3NP, and that's okay. We need that in order to help you. And then lastly, we are really seeking to gauge your interest. We're asking for your feedback on this initiative so that we can also look at how we might be able to expand in the future. As I mentioned at the very beginning of this, imaging is very broad and a very expansive area within healthcare. And so as we look to grow our imaging solutions, especially across the 3 phases of imaging result reports, viewability, and full exchange, we need to understand some other areas or scopes that might be problematic for you, that we can work with you and partner with you to start to begin to tackle. Next slide. So thank you. I'm going to be quiet now for a moment and let you ask questions.
Katie, there is one in the chat from Julie asking, in phase two, after you have the observation reports and are moving to exchanging the images, have you determined the technology needed to store the images and who will cover the costs? Or are you planning to do a query based on the metadata real time?
Thank you. Good morning, Julie. So specifically, I am going to speak to this, and I believe Jason Bismar is also on the call this morning, and so he may need to fill in a little bit of gaps here. But at the end of the day, when we talk about phase two, we're actually going to be talking about how do we bring this information in and not necessarily store it from our perspective, because I think we all are very well aware that image sharing is very expensive and very large. Um, so with this, we're really looking at how can we create what is called a pointer. I think about it more in the respect of a GPS location, maybe. And so if I have, I'm going to use the example I had in my slide deck here, right? If I had patient Trisha, I can actually go in, I can see everything about Trisha. I can see all the different places that she's had imaging performed at. And then I have these pointers available that say explicitly, I can go in and I can click this pointer and I can say, hey, she had a mammogram done here. Um, Click it, view it, and it will go out and query and pull the information back. So we're not talking about us actually storing it. We're talking about making connections to all the different locations where it is stored and available. Jason, if you're on the call this morning, is there anything additional you would add to that?
I think you pretty well covered it. Yeah, I mean, short, it's really looking at the query and retrieve just as the starting point. But I mean, certainly if there's a desire that we want to look more at maybe providing that kind of vendor neutral archive type functionality, even if it's not for the entire state, but for certain organizations. Yeah, I think that's certainly a conversation we can have to see how we want to do that. But our primary focus is really at the query and retrieve level.
Thank you. And Julie, I saw your response. Thank you for the question this morning.
There
Are
was,
there other?
oh,
Oh,
I'm
sorry, Katie.
no problem. Katie's think a lot alike. Eh? There was another asking if you could share where the data came from on the slides regarding the breast imaging percentages, the misdiagnoses, etc.
Absolutely. I would be very happy to do that. That information actually came from, as I mentioned, the physician that really reached out and educated on this. She actually runs a foundation. It is called let me think about this, Operation Breast Density, I believe is the name of it offhand. She would be more than happy to speak with anyone about this. The research that she has done on this is expansive, to say the least. So that did come from us specifically. That did come from a physician who is in this every day. But if you are interested, I would welcome you to go out and reach out to their website, look at the information about it, and specifically reach out to her. Her name is actually Dr. Shoshana Hollowell within the state of Michigan.
Thank you so much. Another chat came in from Katrina. Is there concern for data loss when retrieving, which would affect diagnostic quality of the imaging?
I need to reread that question. Bear with me. For data loss when retrieving, I'm not sure I understand your question. Would you be able to come off mute and maybe elaborate?
Yeah, sure. This is Katrina. I'm calling from the Upper Peninsula. Thinking about when we're transferring images, even from, say, DICOM onto a CD, and then that's put into another hospital's viewer, there's some data loss there, which can inherently affect the quality of the original imaging. I'm wondering if through that process of kind of like querying and retrieving the imaging or the studies, is there any concern for that loss, or is it simply viewing it exactly as if you were viewing it on that health system's viewer?
Got it. Thank you for the additional information. I'll be very transparent and tell you I don't know the answer yet. I don't think that we have delved enough into our phase 2 of this to really have enough information to answer you. What I will say is when we get to the point where we actually are bringing in, basically DICOM information, right? We're going to have to be very cognizant that that is a potential situation. And we're going to have to look at and really peel apart all the different elements of this. And quite honestly, when we get to these points, right, I think I explained we do a lot of recognizance, we do a lot of research to try and figure out what pieces we really do have to solve for. And so I think this is something that when we get to the phase 2 piece, we should definitely look at, and would be very excited to partner with folks like yourself, and certainly others on this call and others more broadly, to understand these situations, and then we will go back and figure out technologically how we might be able to solve them. I apologize, I don't have a better answer for you today.
Thank you.
Dee is asking in the chat, how would other providers have access to this information if they don't submit ACRES files to MiHIN? Will that be a step in the sharing of information with others?
Good morning, Dee. So specifically, if they don't submit an ACRES file, right, there is the potential, if they obviously are legally connected to us through all the paperwork that we either know and love, they would have the ability to go into our MyGateway system and add the patient to an ACRES file, which we really do through what is called our Manage ACRES process. But I believe overarchingly, they would have to create an ACRES relationship with us in general. There is no way for us to do this without us understanding that they do have an established relationship with that patient. So moral of the story, there are a few different ways to do that, right? There is real-time ACRES, there is the submitting of the file. There is also the ability to do Manage ACRES, which, let's say you have a patient walk into your facility, you've never seen them previously, you can enter in the information at that time to create an established relationship with them much more expeditiously. But there is always the need to have an established relationship with them, because from our perspective, we have to make sure that we are providing that information appropriately. And so outside of creating that level of the relationship, I don't believe that we would provide access. Dee, am I missing the crux of your question? I just want to be clear. Maybe I am.
No, not at all. I know that we send our ACRES files in monthly, but I know other offices do not. And to be able to share that information with others would be huge.
Right.
So
So I mean, what the
Down
question,
the road, we just have to work with those other offices to connect with MiHIN and send that information or learn how to send it in. So that was just my question. I know not everyone sends information in.
right? No, Dee, I mean, I think it's a really good point. And I feel like when we're going to have to start here, and I cannot wait personally. We're going to have to start here by saying, like, do the people that you think need to have information, do you know if they are working with MiHIN? Do you know how they're working with MiHIN? And if they are having an issue with somehow, getting us the information we need to make sure that they can legally receive this information, we have to figure out why. We have to figure out what the barrier is, because there are all kinds of ways to set up an ACRES relationship, and we're working every day to try and make it easier. But certainly the easiest would be to do it on the fly in MyGateway and manage those relationships.
I think other offices, even us, one huge barrier that we struggle with is our radiologists that we send our films to will not read our mammograms until they have a previous study. So we will request those studies, and ladies come in and we have this brand new 3D mammogram in our offices are so anxious to have it done, and we have to tell them, we don't have your previous study, so we can't shoot your film. So to have something like this could be a game changer for us.
And I think, Dee, from our perspective, right, like realistically, we are all individual patients ourselves, right? We experience these same things with ourselves, our family, our friends. We know this is a problem. And I think understanding the additional issues that all of you are facing from that perspective on the front lines, if you will, is extremely helpful for us. This type of pilot solution that we're talking about is really the beginning of how we would start to tackle this. From the perspective of not having the priors to read them. At least with this as an example, you could go in and identify where the patient had it done, right? You could identify, here is the results. Admittedly, understanding those radiologists, to your point, won't read them unless they can view the image itself. But that really is the next phase that we have to get to. How do we make that information be viewable so that it becomes much more streamlined? We know, like I said, that this is a problem. And all of you speaking up about these pieces is actually incredibly helpful. I do want to take a step back to your initial question, 2D, about acres. There really is multiple ways to establish those relationships with those patients. I think from my team's perspective, we are also working on different ways that we might be able to promote education on some of those things, and additionally obtain feedback, right? So that we can make changes to how this is done. We can make it more effective. Our goal is to not to make this so bureaucratic or arduous that everybody is like, wow, this takes so much time and it's so painful to do. We need to understand those pain points so that we can take them back and make it better. But from our perspective, I think we are very willing to also delve in and educate everyone at large on what this looks like, and really promote continuous education on it. Additionally, from the perspective of how we get some of these other organizations, we would welcome your outreach to these organizations and saying, to Joanne's point, have you worked with these folks at MiHIN? Here's Joanne's information, here's Lisa's information, whoever it is, we would welcome that approach. You always hear about the best things from other people, as they say, or word of mouth is really the best approach. And again, we welcome that because we know we are stronger with our network of networks approach. We know we are stronger with all of that data coming to one point. So thank you, Dee. Are there others, Katie, that I missed?
I don't believe so. There is one about images being either referential or diagnostic quality, but it looks like Jason might be typing an answer right now to that.
Yep, I was just responding to that one. Our ultimate goal is to be able to support the diagnostic quality. I think as we get into the phase 2 and continue to learn more about what can be made available from the various sites, we may need to start with the referential quality. But certainly overall, and when we look out into where we really want to be, it's giving those options so that you can pull back, the diagnostic quality or even the referential quality, depending on your use case.
Thank you, Jason.
Thanks, Jason. Lisa, I don't know, you want to come off mute and try and get some more, really try and get some more feedback here about these other tests?
Sure. So the previous I think it was Dee who
Yeah.
really highlighted kind of incredibly well the tests and why it's so important to be able to do that. Are there other diagnostic tests that this same kind of principle applies to? Like you can't even perform the test that's been ordered until you understand what the baseline is. Are there other tests that would help us to be able to prioritize, what those high value, high target populations are? Again, being a little more precise than let's just flow images everywhere. And whether it's Dee or whether it's anybody else on the line who understands that.
Let me also say, I know that's a complicated question. If you have answers to that outside of this group today, again, we welcome your outreach and feedback. If you think of something next week and you're like, oh, that'd be a really good, good population also that could benefit from this, please let us know.
For sure, it's got to be driven by clinical need as to what we're doing. So your expertise is really key.
I am not currently seeing anything else coming through the chat. So I think, Joanne, I don't know if you want to leave us with words of wisdom or if you want me to close this out, but I saw you on camera, so I'll let you.
No, yeah, I was just going to say, if anything comes up for you, what does this look like for you? What could it look like for you? What are we missing? What are our blind spots? What are the opportunities? We are all ears. We can't solve problems in a vacuum, and we don't want to solve problems that maybe they aren't problems. Maybe they're, if we are already sending our imaging ORUs to MiHIN, what would it mean to be involved with the pilot? Great question.
Good morning, Chris. So specifically what it would mean is, how could this pilot specifically help you, right? I think we talked through the fact that, again, this first phase is meant to exchange the imaging result reports to start. And I agree with Joanne's point right there. Who are your partners? Who else do you need this information from? What are some of the other points that we might be able to assist you with that we didn't tackle yet, right? How do we make this available to you? Specifically, what this would mean, though, is, like Joanne said, who are your partners? Where do you need this information from? How do we get you access to this information if you have an established patient relationship? And then basically make it viewable and accessible securely within our MyGateway and longitudinal viewer systems. And so if you're interested in this pilot, if there is a way that we can help you help patients or help your communities, please let us know. We want to help you. But in order to sign up with the pilot, it really is just, usually there's a little bit of legal. I'm not gonna lie. There's usually a little bit of legal. And it's talking through that data flow. How can this data flow help you? Are there additional pieces? Are there additional tool sets we have or solutions that can make this easier? And ultimately, how does it plug in or enhance or streamline your workflow? So if you're interested, please let us know. Genuinely, that's a genuine offer.
I'm looking one more time at our questions. I think we got to them. Thanks, Kate. Thanks, everybody, for coming. Oh, wait, we have one more. We have a clinic system that covers 7 counties. We have difficulty getting mammogram results. How do we go about joining the pilot?
I will. Yes, that's what I was going to say, Lisa. Lisa is your lady. Lisa is on the call today, and she would be happy to reach out to you and talk to you about the pilot, talk to you about engagement and the steps, and just quite genuinely how we partner with you on this. So I should be specific. Lisa H, would that be okay with you if Lisa N reached out to you?
And is it possible to just drop me a quick email? I think that Caitlin dropped my email address in there. Just send me a quick email and we can connect and find out a little bit more.
Perfect. Yeah. Is this going to be part of MiHIN or a separate? I guess I didn't understand that either.
Part of what we do.
This is one of the multitude of solutions that we're offering.
Lisa, are you already connected to MiHIN? Lisa Hoekstra?
Hang on, I was trying to copy that email. Yes, we are connected to MiHIN. One of our issues is, as long as we're talking about this, some of the, so in the West Michigan area, I find you have pretty good penetration, but some of the penetration in sort of Central Michigan at those locations hasn't been as good. And I don't know if that's changed recently.
We're going to need to know. Yeah, like we're going to need to know exactly who you want. Because
Okay.
it may be that we already have them and they are not, that is part of what our integrated technology platform is about. We are bringing all of our instances and all of our connections together into one platform. So it may be that if you're looking at a longitudinal record, it doesn't have all of the senders that we really are connected with. I think we want to know exactly who you want to see from, and we'll go get them.
Gotcha. Yeah, we're a tribal health center, so that makes it difficult because people may go up to the UP
Understood.
to get
We have all
services
coverage.
all over. Okay. Great.
Literally, like if anybody here wants to say, like, why aren't these people connected? We work with them. We know our patients are going there. Are these people working with MiHIN? Write to me. Let me know. Give me names. And we'll tell you exactly how we're connected.
Okay. All right. Perfect.
Thank you.
And Dee, I see your question. No, it doesn't matter the number of mammograms your office performs to be part of the pilot. If you need this information, if it helps one person, that is great. It doesn't matter. We are not looking at this saying you need to help 50,000.
And let us know, by the way, if it does help that one person, we are looking for.
Yes. Yes, we want to know that what we're doing is successful. Like, let's be very clear. And I don't know if I made this point during that presentation, but we are genuinely trying to provide valuable solutions. We are trying to figure out, how does this help people? We are definitely still of the mindset that we have a patient-centric perspective, okay? How do we coordinate the care teams? How do we coordinate everybody involved with that patient's care? Thus the ACRES model, let's be realistic here. And so, from our perspective, we want to know how you're helping these people. Any success stories you have actually help us more than you can possibly imagine. And I don't think it's any secret, right, that anybody really who's in this business likes to know when you have made an impact on someone's life. And so when you actually say, hey, we were able to provide this, we were able to, obtain this data, obtain XYZ, support XYZ clinical decisions, that means a lot to us, even personally. It helps us to get up in the morning because the problems that we're tackling are genuinely difficult with interoperability. And so just understand, I think also as you walk away from this call today, our hearts are in the right place. We are genuinely trying to figure out how to improve healthcare as well, even though we are not directly at the bedside. So I don't care, again, if it's one person or 15, we want to help.
And with that, I will thank you for showing up. Thank you for working with MiHIN. We've given you a number of ways to get in touch. I am here. Lisa's here. Katie's here. There's a lot of human beings that work here. We're all human beings still at this point, guys, which is cool. Thank you again. We'll see you next month. Be well.
Thank you.